Welcome back. In Module 1, we explored what agoraphobia is and why healthcare environments can act as powerful triggers for patients experiencing fear of entrapment or panic. In this module, we will focus on a practical and important issue: how anxiety and agoraphobia can present as behavior that appears difficult, hostile, or non-compliant. Recognizing the difference between distress-driven behavior and intentional aggression improves safety, reduces escalation, and supports better clinical outcomes. This module will help you identify behavioral patterns that may indicate anxiety rather than hostility.
Anxiety activates the fight or flight response. When a person feels trapped or overwhelmed, their nervous system prepares for survival. In healthcare environments, escape may feel limited. When flight feels blocked, the response can shift toward fight. This does not mean the patient is consciously choosing aggression. It means the nervous system is escalating. Common outward behaviors may include raised voice, irritability, abrupt or sharp tone, demanding to be seen immediately, refusing procedures, insisting on leaving, challenging staff instructions. From a practitioner's perspective, these behaviors can feel personal, disrespectful, or threatening. From the patient's perspective, they may feel like urgent attempts to survive. Understanding this dynamic reduces the risk of escalation.
There are patterns that suggest behavior may be anxiety-related. Physical indicators: rapid breathing, sweating, trembling, pale or flushed appearance, visible tension, restlessness, clutching chest or throat. Behavioral indicators: repeatedly asking how long something will take, standing near doors, fixation on leaving, refusing to sit, abrupt cancellation at the last moment, difficulty completing forms, insistence on a companion staying present. Verbal indicators: I can't do this. I need to get out. I feel trapped. Something's wrong. You don't understand. These cues often appear together. When observed collectively, they suggest distress rather than defiance.
Understanding escalation helps practitioners intervene earlier. Anxiety escalation often follows this progression. Discomfort, visible tension, scanning environment, heightened questioning. How long will this take? Urgency. I need to go now. Irritability or raised voice, refusal, or abrupt exit. If staff respond with firmness alone, for example, you need to wait. Please calm down. You're being disruptive. The patient's perception of entrapment may increase. This can intensify the fight response. Early recognition prevents this cycle.
It is important to be clear: not all aggression is anxiety-driven. However, certain features differentiate distress from deliberate hostility. Anxiety-driven behavior often includes visible fear, inconsistent intensity, language focused on escape, rapid onset, regret after the episode, relief once outside or in fresh air. Deliberate aggression more often includes goal-directed threats, manipulative tone, lack of visible distress, behavior consistent across contexts, aggression used to gain advantage. The distinction is not always absolute. However, observing physiological signs of panic strongly suggests anxiety involvement. Recognition supports appropriate response.
When anxiety-driven behavior is interpreted purely as misconduct, the patient may feel shamed. Defensive responses may increase. Future appointments may be avoided. Healthcare engagement may decline. Staff frustration may escalate. Repeated negative interactions may reinforce avoidance. Patients with agoraphobia often already feel embarrassed or ashamed. Misinterpretation increases this burden. Conversely, recognizing distress early allows for proportionate intervention.
Recognition of anxiety does not mean tolerating abuse. Clear boundaries remain essential. Statements such as, "I can see this feels overwhelming. I want to help. I need you to lower your voice so we can continue." Maintain safety while acknowledging distress. Validation and boundary setting are not mutually exclusive. Both are necessary.
Consider a patient in a waiting room who begins pacing, repeatedly approaches reception, and demands immediate attention. Without context, this may appear disruptive. With awareness, it may represent escalating panic due to uncertain waiting time, crowded environment, fear of physical symptoms, perceived inability to leave without missing their appointment. A brief, calm interaction acknowledging timing uncertainty may reduce escalation significantly. Early recognition prevents conflict.
Consider your own setting. Where might patients feel trapped? How long are waiting periods? How clearly are time expectations communicated? Are exits visible and accessible? Small environmental adjustments reduce escalation risk.
Anxiety can present as irritability, urgency, refusal, abrupt departure, raised voice. Physical distress cues often accompany behavior. Early recognition reduces escalation. Boundaries remain important. Understanding anxiety does not replace safety protocols, it enhances them.
In this module, we've examined how anxiety and agoraphobia can present as behavior that may be misinterpreted as aggression or noncompliance. In the next module, we will focus on detection, how to identify patients who may be experiencing agoraphobia, even when it is not explicitly disclosed. Early identification allows earlier support and better outcomes. Awareness improves safety for both patients and staff.